Yes, Ms. Richards.
Sir, I'm going to pick matters up in relation to Cardiff and Professor Bloom in early 1983, which is where I left off last week. Before I do so, I should just mention that I identified last week a number of statements that the inquiry had received from nursing or social work staff at Cardiff. I should add, we've also since received and been able to disclose to core participants a statement from Dr. Giddings, who was the scientist working at Cardiff, and a statement from Dr. Liddell, who was a registrar working under Professor Bloom at Cardiff. And those documents have been shared with recognised legal representatives and core participants. So picking things up in 1983, it was obviously a hugely significant year in terms of the response of Haemophilia Centre directors to AIDS, led by Professor Bloom as chair of UKHCDO. If we could have on screen, please, Henry, PRSE 301991. This is a report prepared for a January 1983 meeting of Scottish Health Service Haemophilia Centre and Transfusion Service directors. The relevance of it for present purposes will become apparent if we go to page 7. If we look halfway down the page under the heading Miscellaneous, we'll see under the heading AIDS, it says the attention of the haemophilia directors is drawn to this problem, Appendix 6. It is noted that in the US, the National Haemophilia Foundation and CDC are already conducting a survey and intend to establish a permanent surveillance programme. The information contained in Appendix 6 has been sent to Professor Bloom, chairman of the UK Haemophilia Centre Directors Meeting. So we can see there Appendix 6 is being drawn to the attention of Scottish Haemophilia Centre directors, but also we're told it's sent to Professor Bloom. And if we go on, please, Henry, to, I think it should be page 14, we will see what Appendix 6 comprised. So this is, and we can see the bottom right-hand side of the page, the words at right angles to the text say Appendix 6, and this is the MMWR from December of 1982. We can see that it contains the update, and we'll just look at the text so we can see what was being drawn to Professor Bloom's attention. If we go back, please, to the top of the page, Henry, thank you. Left-hand side, first paragraph under the heading Update on Acquired Immune Deficiency Syndrome. We see reference there to the specific haemophilia patients identified in July 1982. And then it said, fourth line, all 3 have since died. In the intervening 4 months, 4 additional heterosexual haemophilia A patients have developed 1 or more opportunistic infections. And then it says these 4 AIDS cases and 1 highly suspect case are presented below. It's set out there that inquiries about the patients provide no suggestion the disease could have been acquired through other means, such as contact or illicit drug use. All of these patients have received factor VIII concentrates, and all but 1 have also received other blood components. If we go back to the full page, please, Henry. There are then details set out of the 4 cases, and then the bottom right-hand side, we have details of the suspect case, which is a 7-year-old severe haemophiliac from Los Angeles. And then if we could go over the page, please. We can see in the editorial note, it said these additional cases of AIDS among haemophilia A patients share several features with the 3 previously reported cases. All but 1 are severe haemophiliacs requiring large amounts of factor VIII concentrate. None had experienced prior opportunistic infections. Reference is made to 2 of the 5 having died. And then on the right-hand side of the page, about 4 paragraphs down, there is reference to these additional cases providing important perspectives on AIDS. 2 of the patients described who are 10 years of age or less. and children with haemophilia must now be considered at risk for the disease. In addition, the number of cases continues to increase and the illness may pose a significant risk for patients with haemophilia. And then if we go back to that full page, please, Henry, we then see an extract from the further report. This is the bottom right-hand under part of the page, under the heading Possible Transfusion-Associated Acquired Immune Deficiency Syndrome AIDS, reference there to the 20-month-old infant from San Francisco who had been transfused. So that is material that we know from this document was sent to Professor Bloom in January of 1983, and as we can see, also shared with Scottish Haemophilia Centre directors. If we then have up on screen, please, Henry, HCDO 40558. We can see on the 19th of January, Professor Bloom attended a meeting of the Hepatitis Working Party of the UK Haemophilia Centre directors. And we'll see from the list of attendees, it also involved from Oxford, Dr. Ritzer, Dr. Trowell, Miss Spooner, other reference centre directors there referred to, including Dr. Ludlam, Dr. Kernoff, Dr. Preston. And then we see that Dr. Krask welcomed Professor Bloom to the meeting. If we go down to the bottom half of that page, matters arising from the minutes, reference there to the prospective study of factor 8 and 9 associated hepatitis, and that's a reference back to the materials we looked at from autumn and December of 1982 of about the evaluation of hepatitis-reduced concentrate. And we looked last week at Dr. Lane's note of the meeting that's there referred to, so I won't go back to that. But if we can go over the page, please, to the second page of this document, we see it says that Professor Bloom said that as a result of the meeting, that's the meeting that took place in December of 82, as a result of the meeting he and Dr. Ritzer had attended, they had written to each Haemophilia Centre director requesting them not to take part in trials of hepatitis-reduced products on a named patient basis without taking advantage of an evaluation where the powers of the Medicines Committee could be exercised in the interests of the patient. And then there's reference to two specific products. Dr. Lane said that it was unlikely that chimpanzee safety tests would be possible after the first batch of hepatitis-reduced concentrate was produced, and that the results of clinical trials in susceptible patients must be available to evaluate these products. So pausing there, you will recall that we looked last week at a letter dated January 1982. That's the perhaps now infamous letter sent by Professor Bloom and Dr. Ritzer, in which they discuss this issue. This is an additional reason why it may well be that the letter is misdated and should have been dated January 1983, because it fits with the chronology of events in late 1982 and early 1983, and it would appear that what's being referred to here is that letter. But that is a matter, sir, that you'll need to consider further in due course. If we go down towards the bottom of this page, please, Henry, we can see there, it says it was agreed that the Working Party would attempt to obtain the collaboration of all Haemophilia Centre directors in the organisation of trials under Alternative 2, and Alternative 2 was trials with an exemption from clinical trial certificates. And then it said this: questions which should be asked were, 1, the risk of non-A, non-B hepatitis when given to susceptible patients. In view of the results of the Oxford prospective study, these should be patients with no prior exposure to factor 8 or 9 concentrate. So to use the acronym that we've seen used elsewhere, PUPS. It was probable that there would not be enough susceptible patients for the inclusion of control groups in the study of each product, and then further detail set out about the proposal. And then if we could go on to the next page, please. There's then further discussion about the potential protocol for these trials of hepatitis-reduced products. And then if we go down to the heading Acquired Immune Deficiency Syndrome, we'll see there's then a detailed discussion of the current position in relation to AIDS. We're told that Dr. Krask reviewed the developments in the field since the last meeting of the Working Party. At Dr. Kernoff's suggestion, he'd written to Dr. Dale Lawrence at the Communicable Disease Centre, Atlanta, who was the coordinator of the surveillance of AIDS cases and haemophilia A patients in the USA. So far, 10 cases of AIDS had occurred in haemophilia A patients. They had none of the predisposing causes such as heroin addiction, promiscuous homosexuality, or treatment with immunosuppressive drugs, and had occurred in areas of the USA where cases had not been found before. All except one patient were patients with severe coagulation defects on regular factor VIII therapy. The youngest was aged 7 years. Both pneumocystitis carinii and Kaposi's sarcoma had been found in this group, of whom 5 had since died. It seemed possible that factor VIII or other blood products administered to these patients might be implicated. So pausing there, sir, a clear awareness amongst those who attended this meeting of the up-to-date position from the states as set out in the communications we've already looked at.
Well, except this time it's 10 cases.
Yes, yes. So
it's increasing.
Yes. And it would appear that Dr. Krask has been able to receive up-to-date information potentially from the states in relation to that.
So on 10th of December, it's 7 or 8. By this time, less or around about a month later, it's up to 10.
Yes. And then we see it's there set out that the CDC AIDS task force were working on the hypothesis that an infective agent was involved, possibly a virus specific for human T cells. Further support for this hypothesis has come from the report of 3 cases associated with whole blood or platelet transfusions. 2 were in adults who developed AIDS 14 and 18 months respectively after transfusion to cover operations. And then, skipping over a couple of lines, the 3rd case was that of a 20-month-old boy from California who'd been transfused with blood platelets at birth for Rh hemolytic disease of the newborn. And that's the San Francisco baby case. So the explicit discussion of that case and its significance. And then if we go over the page, please, Henry. The first main paragraph, I won't read out the discussion there, but we'll just look at the last sentence of that first main paragraph. 2 recent papers in the New England Journal of Medicine suggested that transfusions of freeze-dried factor VIII concentrate may be a factor. And again, so we've looked already at those publications in the New England Journal of Medicine at the beginning of 1983.
Well, that was the editorial by Janet Deforge saying that we should now move to cryoprecipitate.
Yes, precisely. And clear awareness of that amongst at least these haemophilia centre directors and clinicians. And then we see it goes on to say that the Americans were keen for the UK haemophilia centre directors to collaborate in the reporting of cases of AIDS possibly associated with transfusions of US commercial factor VIII. It set out that no cases have so far been found in haemophilia B patients. And then there is a discussion that's there recorded about the kind of survey that could be undertaken. There's reference to specific American forms for reporting symptoms. Again, a reference to the 2 recent papers in the New England Journal of Medicine and so on. And the outcome is that Dr. Krask will draw up a form for the reporting of AIDS cases and consider what further information would be needed in a retrospective study. So that's the Hepatitis Working Party of the Haemophilia Centre Directors Organisation, 19th of January 1983. That same day, if we have Henry, please, BPLL 301351 _ 071, please. That same day, 19th of January 1983, Mr. Waters of the Haemophilia Society wrote to Professor Bloom in these terms: Dear Professor Bloom, the Reverend Alan Tanner has asked that I write to you enclosing this article from The Observer of Sunday the 16th of January. Pausing there, I won't put the Observer article up, but it's referred to in the Knowledge of Risk chronology, and I think it may have been one of the documents I displayed last week. We are writing to you in your capacity as chairman of the Centre Directors Meeting and our own medical advisory panel to seek some clarification on current thinking in the UK on this matter, which has naturally raised some anxiety with calls coming from as far away as The Hague. It would be most helpful to us if you could offer guidance at this stage with the possibility of an early date article for the bulletin so we can keep our members in touch with the situation. So pausing there, we will see from various communications and publications throughout the course of 1983 that the Haemophilia Society turned, unsurprisingly, to Professor Bloom for advice on the specific issue of AIDS, with a view to working out what it should be telling its members. Professor Bloom's response is dated the following day. So it's at HCDO 603_066. So 20th of January, Professor Bloom will have attended the meeting on the 19th that we've just looked at, and we'll see what he says to Mr. Waters of the Haemophilia Society. Thank you very much for your letter and for the cutting from the Observer. This cutting does seem to have caused some concern amongst the patients and indeed some medical administrators and physicians. There may be a modicum of justification for this concern. You are no doubt aware of the background that a rather serious new disease began to be recognised towards the end of 1981, particularly amongst homosexuals in the USA. And then he summarises the emerging knowledge in that respect. And then a few lines down, picking it up, he says this: however, later, as detailed in the Observer article, several groups of people who were clearly not homosexuals, including various immigrant groups in the USA as well as the 10 haemophiliacs, were identified as suffering from the disease. Clearly, at the present time, the cause is quite unknown, and neither has it been proven that it is transmitted through contaminated blood products. The incidence of the condition in America is not known, but seems to be about 1 per 1,000 of the severely affected treated patients. On this basis, if the disease exists in the UK, we could reasonably expect 2 or 3 cases among British haemophiliacs. So far, none have been reported. Pausing there, sir, of course, at some point you will no doubt wish to consider whether there is a fallacy of reasoning in this advice, given what was known about the potential lapse of time between infection and symptoms being displayed, and whether there is a conflation of incidence and risk. Continuing with the letter, he says this: the Haemophilia Centre Directors Organisation is closely monitoring the possibility of this condition in the UK. And then he refers to the Hepatitis Working Party, which was the previous day, and the retrospective and prospective surveys that are proposed. And then he says, as the full-blown condition has not yet been reported amongst British haemophiliacs, it is not possible to state if the coagulation concentrations produced in this country are safer in this respect than the concentrates produced in the USA. Indeed, there is no evidence yet, in fact, to implicate the latter. However, the directors of several individual centres are investigating possible markers of the condition in patients who receive various types of blood products. So as at January of 1983, Professor Bloom is there explaining that there are some directors who are already investigating possible signs of the condition.
I'm just puzzled by the first full sentence on that page. Indeed, there is no evidence yet, in fact, to implicate the latter, that is, to implicate the concentrates produced in the USA. I can understand his saying the cause is unknown. I can understand him saying there is no proof, if proof is what it is necessary to look for, that is, proof of effect, a cause and effect. But no evidence seems to be a surprising claim.
Yes.
Yes.
And then he says this, and this is effectively the message that he's then sending the Haemophilia Society. In the meanwhile, there is certainly no need for the haemophiliac community to be unduly concerned about this new syndrome. They can rest assured that every effort is being made to monitor the situation in this country and to collaborate with the Centre for Disease Control in the USA. Although no cases have been reported in the USA, as far as I know, in haemophilia B, we are monitoring the situation in all these related conditions. As you and your colleagues in the Society know, coagulation factor therapy is so essential for the safety and well-being of patients that there is no doubt whatsoever that their advantages far outweigh this disadvantage, which at the moment seems to be potential rather than real in the UK at any rate. Further developments will depend upon identifying the responsible agent or constituent of concentrates if it exists, and no doubt then steps can be taken to eliminate them in much the same way as steps are being taken to reduce the risk of hepatitis. We'll see shortly the publication that results a little later on in that year, authored by Professor Bloom and published by the Haemophilia Society. But in the meantime, staying with January of 1983...
So just as a matter of interest, did, in the event, Dr. Krusk write an article for the Haemophilia Society?
I don't think so, sir. There are... I'll need to check and maybe I'll have to give a more positive answer to that, having done so. My recollection is the first bulletin of 1983 contains that question and answer session with Dr. Kernoff about AIDS, which we looked at last week, in which he suggested that an epidemic of AIDS was a ludicrous suggestion. I don't recollect there being an article by Dr. Krusk in that bulletin. I'll check the numbers of bulletins, but I think the next bulletin in 1983 contains, or there is a message from Professor Bloom in one of the next publications. But we'll check there. Certainly Dr. Krusk authors a lot of material in the course of 1983. Well, but for the most part, it seems to be shared with the Haemophilia Centre reference directors and working parties.
Yes, it may be that he took a slightly different approach to the risks than did Bloom.
Well, we've certainly seen, I think, in a report from November 1982, which we looked at last week, the three possibilities being set out in terms of causal agent by Dr. Krusk, and an inference, perhaps the most reasonable inference to draw, is that he thought the most likely of those possibilities.
Well, he discounts two of them.
He does.
That leaves only infectious agent.
Yes. But so I'll check, because it is possible that there might have been an article in the bulletin that I'm not aware of. We then come a few days after this letter to that meeting on the 24th of January 1983 at a London airport hotel. We looked at the minutes of this meeting last week, focusing on what it said about AIDS. I want to go back to the minutes and look at, again, what's said about AIDS, but also what's said about hepatitis. You'll recall, sir, that there are two records of that meeting. The first is a record prepared, we think, by Dr. Bolton, and that's PRSE 302647. So we see notes of meeting with Immuno at London Airport, 24th of January. The topic is hepatitis reduced factor 8 and factor 9 concentrates for haemophilia therapy. If we go to the last page, please, first of all, Henry. We can see there the list of those present. It includes, relevant for the purposes of this week's presentations, Dr. Ritzer, and Dr. Bloom, but it includes a number of leading Haemophilia Centre directors, as well as Professor Zuckerman, who was a leading expert in hepatitis. And then we'll see it says the Immuno team were led by Dr. Ebel. So there were representatives of Immuno at the meeting. And indeed, it was a meeting convened to take place with Immuno. If we then go to the second page, please, of this note, under the heading Clinical Trials Design, so this is in relation to the so-called hepatitis-reduced products, there was some considerable discussion over the nature of the design. Dr. Krusk, in preliminary comments, pointed out that in work with Dr. Ritzer, rather to their surprise, over 18 months, 30 patients with no previous history of exposure or only slight exposure had been recruited to a study of the incidence of non-A, non-B after factor 8 concentrate. These patients included patients with von Willebrand's disease and mild haemophilia, and incidentally indicated that completely unexposed patients had 100% incidence of hepatitis with BPL factor 8, and that patients who'd previously received 4 to 5 batches of material had a 50% chance of developing non-A, non-B hepatitis. So that's a report of a study that had been undertaken at Oxford by Dr. Krusk and Dr. Ritzer. And then there is then discussion of the new trial that is proposed. Picking it up at the bottom of that page, it would appear that the issue of using children in the trial had been raised, because it's then recorded that Dr. Hill and Professor Hardisty, so that's Birmingham and Great Ormond Street respectively, pointed out the ethical difficulties of using newly diagnosed children as first candidates in the trial. This is because children may be safer on cryoprecipitate, because of the possible toxic effects of the added chemicals, and also because of the need for considerable follow-up venipunctures, which in the context of general ethical difficulties with working on children as experiments must be a severely limiting factor. After some discussion, it was agreed that trials should initially take place in adults, and particularly those who require large doses of factor VIII frequently. Such patients could be used for assessing data on recovery, half-life and toxicity. When such patients reveal satisfactory data, the next stage is going to adults who have only occasional requirements. However, these adults would have to have a good reason for not receiving the cryoprecipitate or DDAVP, such as major surgery. After an initial period of satisfaction in such patients, one could then go to children. So that's the discussion about the proposed trials in relation to the hepatitis product.
Well, just pausing there. This paragraph is suggesting trialling on adults who require large doses of factor VIII frequently. The letter we looked at of the 11th of January 82 or maybe 83 was talking about previously untreated patients as the only way you could work out whether heat treatment worked.
Yes.
This is looking to see if heat treatment works by treating those who have been not only previously exposed but heavily exposed.
Yes.
Because it must be the case, haemophilia being a lifelong condition, that if they are serious as adults and require large doses of factor VIII frequently, they would have done so for a long time.
Yes. We do have protocol in relation to this trial. I think it postdates this meeting rather than predates it, but I'll check, which I'm going to deal with when we deal with Oxford, so we can perhaps revisit that question at that point.
Probably an explanation which is escaping me at the moment, which is scientific as to how the effectiveness or otherwise might be gauged.
Yes, I don't know. So we must recall these are the notes taken by Dr. Bolton, of course, and won't necessarily reflect a complete account of the meeting. We then have, under the heading of acquired immunodeficiency syndrome, this was discussed in the after lunch period, and then I won't go through the detail of this because we looked at it during the knowledge of risk presentation last week. But there is a detailed discussion, including data that up to 10%, up to the 10th of December 1982, 800 people have been reported as suffering from AIDS with a 45% mortality. And then details given of the 10 cases in the US. And if we just go to the last page, please, Henry. Fourth paragraph down, it says the attention of the meeting was then drawn to the 2 articles on the editorial in the New England Journal of Medicine on the 13th of January, which in summary indicates that the T4-T8 ratios among haemophiliacs receiving factor VIII is greater among those who've been exposed to concentrates than those exposed to cryoprecipitate only. However, cryoprecipitate in the US comes from volunteer unpaid donors and therefore are presumably well-motivated people. So we've seen how at the smaller meeting on the 19th of January, the New England Journal of Medicine article is discussed. Here at a meeting involving a larger cohort of clinicians from haemophilia centre directors, the attention of those present is being drawn to that article again.
And the letter, so far as you have drawn it to my attention, makes the points that it may well be an infectious agent, that the incubation period is a long period, that's the top of the second page, I think, and that the mortality rate is getting on for half at that stage of those who've been already diagnosed.
Yes. And then we'll just look at Immuno's own note of the meeting. Henry, this is at DHSC 301800. We see from the covering letter that it's being the note is being sent on the 18th of March, some weeks later, to Professor Bloom. I had much pleasure in enclosing the summary of discussions of the meeting held at the Excelsior Hotel, Heathrow Airport, on Monday, the 24th of January, 1983. If we go to the next page, please, we'll see under the heading that Professor Bloom chaired the meeting. This sets out in more detail than Dr. Bolton's note what was being explained by the representatives from Immuno. And then if we go to the next page, please, Henry. Second paragraph, we see that Dr. from Immuno is then recorded as saying that guidance was required from the meeting as to the correct procedure as far as future use of these products were concerned, and the following points were made. 1, young children could not be used for trials as neither they nor their parents could give consent. 2, adult haemophiliacs with an established immunity to non-A, non-B hepatitis would not benefit from a trial, but it was thought that they would be sufficiently public-spirited to agree to these materials being used on them to show hemostatic effect and absence of toxicity due to remnants of additives. 3, all batches of NHS and US commercial concentrates have been shown to be capable of transmitting non-A, non-B hepatitis. It's believed that a 1 in 50 chance of transmission from cryoprecipitate occurs. 4, because of 3, many thought it would be difficult to justify carrying out a prospective controlled trial. However, it was generally agreed that sufficient susceptible adult patients needing high-level treatment, e.g. for surgery, could be identified to warrant uncontrolled prospective trials of this and other virus-inactivated products. It was agreed that such trials should be instituted. And then I can skip over 5. 6, it was not practical to test every batch in animals. In fact, it's hoped that the requirement to test batches of HB vaccine in chimpanzees will soon be discontinued. However, it is intended that 3 consecutive batches will be tested in animals. 7, maximum effort so far had been to show clearance of non-A, non-B hepatitis, which is regarded as the main problem. Later on, tests will be made on the effect of both methods on hepatitis B and possibly other viruses. And then over the page, we can see a summary. So I've already noted, I think, in the knowledge of risk presentation last week at paragraph 13, there's just a passing reference to AIDS in this note from Immuno. And then we see Professor Bloom summarising the meeting as follows. A, clarification should be sought from DHSS as to whether the treatment of the final product could be covered by a product licence variation or if a clinical trial exemption certificate was necessary. It was agreed that the best procedure would be to seek a product licence, if necessary, via clinical trials in preference to use on a named patient basis. B, hemostatic activity in terms of in vivo recovery and half-life and absence of toxicity should be ascertained in adult haemophiliacs. C, the material should then be assessed in the treatment of adult haemophiliacs susceptible to non-A, non-B hepatitis by a properly conducted trial in susceptible patients in appropriate need of treatment. It was agreed that it should be possible to identify sufficient UK patients for such trials. D, the material could then be used on newly diagnosed children. E, trials could be arranged by the committee of the haemophilia directors, and it would be best to use 5 separate batches with 2 patients receiving each batch. So that's the second account that we have of
Can
that
we just
meeting.
go back to the opening, the cover letter, please?
Yes. It's the first page, please, Henry. It's the first page of this document. DHSC
001.
1800. I think the system's frozen temporarily, sir. Thank you, Henry. So that's the covering letter, sir.
Yes, it's not, therefore, minutes as such.
No.
So the reason I ask is that the normal protocol would be, I think, that the chairman at least reviews the minutes before they're released. The chairman here was Professor Bloom. So this is not necessarily minutes for which Professor Bloom is at all responsible.
No. And indeed, we don't have anything that would be regarded as minutes. We have two notes giving the authors separate accounts, one from Professor Bolton, one from, I think it's Mr. Berry of Immuno. So we don't have any formal minutes. It doesn't appear that the meeting was in fact minuted. And one matter you may want to consider in due course, when you look at respectively the litigation reports produced by Professor Bloom and Dr. Ritzer for the purposes of the HIV litigation, they record a number of meetings, but there is not, as far as I can recall, any discussion of this meeting. I'll double check that because we're going to look at both of those litigation reports at some point either today or next week. But that certainly is my recollection. If we just then please, Henry, have on screen whilst I find the reference. Yes, WITN 004 7004. We go to the next page. We can see here, and this is a communication from Dr. Liddell, Registrar, under Dr. Bloom, of the 28th of January 1983, to, I think, probably a GP. We can see that awareness of AIDS or some awareness of AIDS and the risk of AIDS is reflected in this letter. We can pick it up in the second paragraph. Being a well-read man, he, that's the patient, is somewhat concerned about the possibility of acquiring the acquired immunodeficiency syndrome, although, of course, there is no grounds for suspecting the diagnosis in him. And it's interesting, perhaps, to see the way in which that's put, sir. I think you may have commented on this when we heard from the patient's widow last year. It's not suggested that the possibility of acquiring AIDS is an absurd or unfounded suggestion. What's being said there's no grounds for thinking that this particular patient at this point in time has it. So clearly awareness amongst those working with Professor Bloom of the potential connection with AIDS for haemophiliacs at that time. If we then move to February of 1983, could we please have Henry HCDO 40411. If we go to the next page, please. We can see here, these are the minutes or draft minutes of the 16th meeting of Haemophilia Reference Centre Directors held at the Royal Free Hospital on Monday the 14th of February 1983. So this is the next Reference Centre Directors meeting. We can see the attendees. Professor Bloom is in the chair. We can see that Dr. Ritzer is there, Dr. Ludlam, Dr. Matthews also from Oxford there, Dr. Savage, Dr. Tuddenham, etc. And then if we go, please, Henry, to page 5. So page 4, my apologies. We see bottom half of the page, there is a report from Dr. Krask from the Hepatitis Working Party and reference there to there being an amended protocol for the prospective study that we've seen being discussed at in the various documents we've already looked at. Dr. Krask asks for feedback from Haemophilia Centre Directors. And then if we go to the next page, we have under the heading AIDS syndrome, we have an update from Professor Bloom. Professor Bloom said that the syndrome would be discussed at the Stockholm meeting of the World Federation of Haemophilia. I can't remember off the top of my head the exact date, I'll check, but we know that in due course that was attended by Professor Bloom. Reports from the US indicated that the incidence of AIDS was higher than at first thought, and there was some concern that the haemophiliac population of the UK who had received American concentrates might be at risk. Then we see Dr. Krask again summarising the latest information from the US, reference to the 10 cases, approximately 10 cases thought to have occurred in non-haemophiliacs there in the UK, and then reference to the form that was being drawn up and a lengthy discussion about the report form and which of the various documents which Dr. Krask had obtained from the US should be circulated to the Haemophilia Centre directors. So at the moment, we've not been able to work out precisely what documents are being referred to there other than the various forms that were proposed on which directors were going to be asked to report possible AIDS cases to Dr. Krask. And then you'll see it was agreed there should be a new form drawn up, and that will be circulated with appropriate notes regarding the criteria on which the diagnosis should be based, and a suggestion that an immunologist be invited to join the hepatitis working party. If we then go, please, still in February of 1983, to CVHB 602 _ 003, please, Henry. You don't have it? CVHB 602 _ 003. No, well, I'll read out the letter and perhaps we can rectify showing it on the screen later. It's a letter dated the 18th of February 1983. It's dear blank. It appears to be a pro forma letter that was going to be sent to patients. Whether it was sent or not, and if so, to which patients, we don't yet know. It's from Professor Bloom and Dr. Moffat, and it says, Dear blank, you may already be aware of recent reports in both medical and general press of unusual infectious illnesses occurring in patients with haemophilia. We have it. Thank you, Henry. There is no cause for alarm, and we stress that the occurrence of these illnesses has been extremely uncommon and has been confined to the United States. On the other hand, it's important to identify any predisposing factors to this type of illness in patients suffering from blood coagulation disorders. To this end, we request your cooperation in a limited survey of patients registered with the Haemophilia Centre in Cardiff. You would be asked to attend this hospital for a straightforward blood test and also a simple skin prick test on the forearm. This is too trivial to require cover by concentrate treatment and will only take a few minutes. If you're willing to have these tests performed, please complete and return the attached form. We will then contact you directly to arrange a suitable weekday morning when the tests can be performed. So, as I say, we haven't yet married up this letter with any of the particular sets of patient records that we've looked at so far to know how extensively it was circulated or indeed whether it was sent. But this appears in documentation provided to us by the relevant health board in Cardiff.
In terms of the drafting of the first two sentences, the occurrence of these illnesses has been extremely uncommon and has been confined to the United States. That, of course, doesn't fit with what Dr. Krask was saying about the fact that AIDS had been seen in non-haemophilia patients in the UK.
Yes, it's accurate
so
only if
the
you read it.
reconciliation must be that he's talking about just patients with haemophilia.
Yes. Although that's not what it says in terms, but yes, that is one possibility.
That's a possibility. Although at this stage it was known that the World Federation of Haemophiliacs meeting in Stockholm was going to discuss the problem.
Yes, I think that's right.
Yes, I see.
And of course there was a lot more information available to Dr. Bloom and his colleagues, not least from the transfusion, the San Francisco baby case and others, from the various medical reports that we know he was aware of.
Yes.
We know that by March of this year, Professor Bloom was making inquiries in the States directly himself. And we can see that from BPLL 301351 _021. This is a letter from Dr. Bruce Evett, the director of the Division of Host Factors at the Centre for Infectious Diseases in the States. It's a letter dated the 7th of March 1983 to Professor Bloom. Dear Arthur, thank you for your recent inquiry concerning the AIDS syndrome. So it would appear Professor Bloom has been in contact with Dr. Evett. And then he says this: I will be happy to present an update on the current status of AIDS in North America during the Stockholm meeting. As you can imagine, AIDS is having a major impact on the treatment of haemophiliacs here presently. The evolution of the epidemic is occurring with a frightening pace. We now know of over 1,150 total cases in the United States. To give you an example of rapidity of development, approximately 80 patients with AIDS reported to us during the month of December. In January, 120, and in February, the number is approaching 20% above that level. In fact, about 40% of the cases have been reported to us in the last 3 to 4 months. We presently have 13 confirmed haemophiliac patients with AIDS in the United States. One of the patients has factor IX deficiency, one is bisexual. In addition, 5 more highly suspect cases are under investigation. The incidence rate has been increasing in haemophiliacs, and the epidemic curve parallels that of the total epidemic curve. The first case appeared in a haemophiliac in January 1982. A total of 9 were reported by December. Of those, 8 died in 1982. From preliminary data obtained from a nationwide surveillance, the AIDS syndrome was the second cause of death among haemophiliacs in 1982 in the US. Hemorrhage was the largest cause of death. AIDS has developed in both mild and severe haemophiliacs. Ages have been 7 to 62 years. The clinical course has been rapid after the onset of an opportunistic infection. Most have had PCP, none have had Kaposi sarcoma. All have received factor VIII concentrates, and all but one have received other blood products such as plasma or blood transfusions. Common lots among the concentrates have been rare. We've accumulated a large amount of clinical data on these patients, and it's very similar to that seen in other cases of AIDS. And then he goes on to talk about studies being undertaken in the States by CDC. And then over the page, he says this: transfusions as a source of AIDS infection is another cause for concern here. Approximately 12 patients have developed AIDS following blood transfusions. These cases are under intensive investigation by us. Of these patients, half are male and half are female. They appear to be located in the high incidence areas of AIDS, i.e. New York, San Francisco and Los Angeles, locations where we would expect the majority of donors with AIDS to be. I hope this information is useful to you. I suspect it is a matter of time before you begin to see cases in the United Kingdom.
Could you just go back to the end of the previous page?
Certainly, sir.
No, the second page. Oh, is this the previous page?
This is the first page,
I
yes.
beg your pardon. It's the bit at the bottom which caught my eye. Preliminary data suggest.
Oh, so you're right, I should have read that. It's important. Preliminary data suggests that 1/2 of the haemophiliac population has T-cell abnormalities, and in fact 13% are markedly abnormal in the range that we see with the AIDS patients.
Yes, thank you.
So, again, you will no doubt wish to consider in due course the terms in which that letter was written and the information that would have been available to it from Professor Bloom. We can see also that Professor Bloom was receiving communications from pharmaceutical companies on the issue of AIDS. So if we have, please, Henry, CBLA 5060_067. This is a letter dated the 16th of March 1983 from Alpha Therapeutic Limited to Professor Bloom. Dear Prof. Bloom, acquired immunodeficiency syndrome. Following the recent upsurge in interest and media publicity regarding this problem, I've obtained from our parent company in the USA, Alpha Therapeutic Corporation of Los Angeles, more details of the precautionary steps that have been introduced to minimise the risk of this disease being transmitted via our pool of donors to the haemophilia population. They are as follows, and then he sets out the steps which it said Alpha will be taking in terms of donor screening and provision of information to donors. He then says, I also attach a transcript of a press release issued by the corporation in January 1983. I hope this adequately demonstrates the company's rapid response to the concern expressed by the medical community, and that we appear to be leading the way as far as major plasma fractionators are concerned to make our final products as safe as possible. And if we could go over the page to the press release, please. So this is an Alpha press release from the State, 7th of January 1983, being provided to Professor Bloom in March of 1983. If we go down to the second half of the page, please. Having referred to the new Alpha policy, which the letter describes, we're told it was initiated in response to a request from the National Haemophilia Foundation, which recommended late last year that individuals belonging to these high-risk groups be excluded from donor pools. The Foundation issued its request after a half dozen AIDS cases were discovered among haemophilia patients. And then the next paragraph, and this is from a pharmaceutical company in January of 83. The evidence suggests, although it does not absolutely prove, that a virus or other disease agent was transmitted to them in the factor VIII concentrate derived from pooled human plasma, which they rely on for life and for sustaining a relatively normal lifestyle. So an acceptance there of the likely cause of transmission to haemophiliacs. And that's being drawn to Professor Bloom's attention in March of 1983. We can see, if we look at a document from that same month, what was being done by the Haemophilia Centre Directors Organisation. So if we have HCDO 40/517_001, please. So this is a letter from Dr. Krask, Dr. Ritzer and Professor Bloom to Haemophilia Centre directors. We assume it's to all directors and not just to reference directors. I think that's a fair assumption. It's the 22nd of March 1983. Dear Director, acquired immune deficiency syndrome. Recent discussions in both the Hepatitis Working Party and a recent meeting of the reference centre directors have prompted us to circulate the enclosed papers so that a system for the reporting of possible cases of AIDS can be quickly set up to examine the problem as quickly as possible. This was initially prompted by a request from the US Public Health Service to the UK Haemophilia Centre directors. We can then see there are papers referred to which set out the criteria for reporting cases, a paper / AIDS 2 and AIDS 3. And then we see in the penultimate paragraph, we do strongly urge you to collaborate in reporting cases of this syndrome, as it is most important that the extent of the problem is quickly identified so that preventative measures can be instituted as soon as possible to minimise numbers of cases occurring in the UK. So you'll see, sir, the response at this stage of the Haemophilia Centre Directors Organisation is to set up a reporting system, but not to change or recommend changes to clinical practices in any respect. The question of the provision of information to patients is not addressed at all. You, sir, may want to consider in due course whether what's set out in that penultimate paragraph is a case of shutting the stable door after the horse is bolted or not. There are then attached to this the various forms referred to. I just want to go to one of them. I think it's page 7, Henry. Do you want the reference again? It's HCDO 40/517_002. So it's this document, but it should be the 7th page of this document. whilst Henry tries to get that up, sorry, we're having problems with the speed of the system this morning. I'll describe what it is. It's called it's aid/1. So it's one of the documents being circulated to haemophilia centre directors, and it's a narrative account of understanding of the current position in relation to AIDS. It is in fact in very similar form to have I given the wrong reference? 002. Okay, let's try again. Henry, I might have given you an inaccurate reference. I think I have, sorry. Thanks, Adam. HCDO 40/517_002. It wasn't a seventh page of 001, sorry, Henry. Thank you. Thanks. So this is in very similar form to that report that we looked at from Dr. Krask in about November of 1982. We can see, if we go halfway down this page, we see reference there to the extent of opportunistic infections, and then in the last paragraph, a considerable delay was noted between the occurrence of initial symptoms and diagnosis. This meant that there was an average 3 to 6 month delay between the onset of symptoms and diagnosis. The signs and symptoms were in most cases insidious and non-specific in nature, and then over the page he sets them out. If we go to the third page of this document, please, Henry. We see under the heading etiology, several theories have been advanced. It seems likely this is a new syndrome. And then we have the 3 theories that we saw in that earlier paper, sir, set out. And if we go over the page to the 4th page, we can see there the third incorporates the reference to possibly the transfusion of commercial blood concentrates. And then Dr. Krask goes on to say, if 3 is the most likely cause, then it's possible that such an agent might be present in the plasma pools used to prepare commercial factor 8 and 9 concentrate, manufactured from donor plasma collected in the USA. And then he adds, 3 patients have acquired the disease where the most likely mode of transmission was blood or platelet transfusions, and provides further detail of those patients. Refers to 5 having so far died. Then refers to the possibility of sexual transmission. And then the next page, towards the bottom of the first paragraph, all the epidemic...
Well, I think if you start at the top, actually.
Certainly, sir. It's also possible that the initial phase of the disease, characterised by enlarged lymph nodes, which is associated with the proliferation of lymphoreticular cells, the onset of autoimmune disease, and he gives examples, loss of weight and malaise, may not always progress to the final syndrome, when marked depletion of the lymphoid cells is the most obvious appearance on histology of lymph nodes. It's therefore evident that the disease is not universally fatal, and some patients may recover. All the epidemiological evidence is consistent with the existence of a transmissible agent whose mode of spread is remarkably similar to that of hepatitis B, which of course have been known for decades was transmissible through blood and blood products. Precautions against cross-infection should therefore be based on those taken for hepatitis B. It is thought likely that batches of factor 8 concentrate which might contain the AIDS virus came into use since January the 1st, 1980 in the USA. And then he goes on to refer to the CDC reporting request. And we see that...
Just looking at that for a moment in terms of timescale, there are 2 periods then are there contemplated by this information sheet. One is the period between first symptoms arising and diagnosis, which is 3 to 6 months in itself. But before the symptoms ever arise, this would suggest there is a period of a longish period.
Yes.
Before they do.
Yes, absolutely. And this is dated the 1st of March 1983, and we know from the reference in the Dear Director letter that we looked at, this is material that is being sent, as it would seem, to all haemophilia centre directors in the United Kingdom. If we then, please, Henry, have CBLA 301693_002. We can see that also in March of 1983, this is headed draft letter. There's no reason to think it wasn't sent, but I should point that out. It's a letter from Dr. Krask, Dr. Ritzer and Professor Bloom again. Dear Director, so again, one assumes to the Haemophilia Centre Directors of the UK. And it's on this issue of trials of hepatitis reduced factor 8. The Hepatitis Working Party has drawn up the enclosed protocol as a result of discussions at the Haemophilia Reference Centre Directors meeting, the use in trials of this product to assess the efficacy of the different methods used for the removal of hepatitis viruses. You will see that the class of patients to be given these products are those who have had no previous treatment with factor 8 concentrate. So previously untreated patients are now the class of patients identified in the protocol. And the protocol itself is at CBLA 301693_003. Thank you. And this particular document is a draft that was sent to members of the Hepatitis Working Party for comment. We don't know for sure at the moment, one way or another, if it was the final version. But we can see there, under the heading Trials of Hepatitis Reduced Factor 8 Concentrate in the NHS, Assessment of Residual Infectivity. Details are set out of the trials that are going to be undertaken. I won't go through the detail of it now, but if we go to the bottom of the page, I'm under the heading Methods. The decision to include any patient in these trials will be made by the director of the local haemophilia centre responsible for the care of any patient, based on the following criteria. Subjects will be selected from infrequently treated patient groups who have not previously been treated with factor 8 concentrate. They should not have received any blood products in the 6 months prior to entry into the trial, and preferably have received less than 50 donor units of cryoprecipitate or 3,500 factor 8 units in the past. They need to be hepatitis B negative, etc. They should have had no previous hepatitis. And then I should point out, it said at the bottom of the page that the object of the study will be explained to them and their consent or that of their parents obtained if under 16 years of age. And then over the page, we see what's proposed is there'll be a full clinical examination with special reference to liver disease. A full blood count and liver function tests will be taken. And then patients will be followed up for 52 weeks following their treatment episode in the absence of any transfusion hepatitis. And we see reference there to the various liver function tests and blood collections in the course of the trial. We see the definition of hepatitis then set out. A patient will be considered to be suffering from acute hepatitis if he develops clinical symptoms and signs as described in Form C1, or shows an increase of at least 2.5 times the upper limit of normal serum aminotransferase levels, having had normal values previously. And then under the heading Follow-up at the bottom of the page, patients whose liver function tests remain elevated for 1 year after the acute attack of non-A, non-B hepatitis or become carriers of hepatitis B virus will be referred to the local liver clinic for investigation of chronic liver disease. Liver biopsy will not be carried out unless clinically indicated. And then the next page, we see there'll be various assessments at intervals of the incidence of acute hepatitis, both B and non-A, non-B. So that's the protocol for the study, and you'll see there the category of patients and the clear recognition there of the possibility of liver disease. Still in March, I'm afraid. Oh, I've note the time, so should we take a break now?
Yes. As last week, for those of you who were here and for those of you who weren't, we're taking 45 minutes for a break. the reason it's as long as that is to make sure that you have a chance to go and have refreshments brought to you at your designated seats and have time to get there socially distanced, keeping safe as you do. We do try to our best to keep everyone as safe and secure as we can in these difficult times. So I look forward to seeing you back. That will make it 11:50, 10 to 12. Shall we make it 40 minutes, because there are perhaps less of you this week than there were last?